Good evening, sir.
Good evening. Greetings to all of you. This is Chandra Mohan, physiotherapist from Tamil Nadu, India. A warm welcome to Exercise Testing and Prescription Organization's free online webinar on visceral manipulation. Today, we have participants from Sri Lanka, Bangladesh, Pakistan, Saudi Arabia, Kuwait, Malaysia, Philippines, Nigeria, Cameroon, Canada, Nepal, and Germany. This shows the eagerness to learn, though the time in different parts of the world is different. I hope you all are safe and staying healthy and strong. Now, without wasting time, I welcome our resource person, Associate Professor Dr. Prem Venkatesan, PhD in Physiotherapy, Manipal College of Professions, Bengaluru. He is a cardiovascular physiotherapist and also practices different techniques after receiving license or authorized certificate. He has already taken a webinar in our ExRxIndia on the topic of asthma, which was really helpful for the physio community. Now we are having him again to teach us about visceral manipulation. I welcome you, sir.
Thanks for your introduction, Mr. Chandramohan. It's a pleasure to be with you and with all the participants. It's a nice opportunity.
Thank you. You can do sharing the screen, sir. While sir is sharing the screen, there is an important announcement. There will be MCQs asked for every 5 and 6 slides. Try to answer in the comment section of our YouTube live link. We will be reading your answers here in the Zoom meeting. Thank you, sir. Please carry on.
Is that visible?
Yes,
my
sir.
PowerPoint?
Yes, sir.
Yeah.
Yes.
So good evening, all. Welcome to the webinar on Introduction to Visceral Manipulation. So I'm just starting with a small case history. A person, Mr. X, with the age 19 years. And the occupation is a student. He's studying engineering college. And he comes with a chief complaint of pain over left chest for past 2 months. No history of trauma. Only relevant history he gives. He lost his father 4 months back. It was gradual in onset. His VAS or the pain scale was 8 out of 10. And he already met cardiologist, took a ECG, took an echo. Everything was normal. And he met an orthopedician again on musculoskeletal examination. Everything was normal. But still he complains of the pain on the chest. That's what he has come and he got, he came to meet me. I just wanted you to just think about what are the possible reasons why he has got this pain. So pain is real, okay? And what could be the possible source of pain? And as a physio, is this patient within the scope of our treatment? If yes, what can be done for this patient? I just want to think about this case scenario. We are going to discuss again further at the end of the session about this case. So for the session today, what are the objectives? What we are going to see today is why visceral. So you've got so many systems in the body. Why visceral? And movement system, which is our bread and butter as a physiotherapist. What is the role of visceral system in the movement? Let it be a shoulder, hip, or lumbar. Does it have any connection? The visceral organs and the musculoskeletal system. And what is the relationship? Is it relevant? So that's what we are going to see. Then I'm going to share with you almost like 4 to 5 cases whom I have treated. What is their presentation? And what was the treatment done? What was the outcome? So I'm going to share with that. Also, what is the possible mechanism of action? How it would have worked? And also I'll be sharing with you some of the research evidences on visceral manipulation. So why visceral? So if you go back and see the Hippocrates, what does he say about visceral? Hippocrates, more than 2000 years back, what he said is all disease begins in the gut. It's not only in this, even in our Indian system of Ayurveda, which strongly believes that all the diseases starts from the gut, and that's how they classify the patients, and then they treat them in Ayurveda also, which they believe that most of the disease starts from the gut. And this word visceral manipulation was coined by Dr. Jean-Pierre Barrel, an osteopathic physician and a physical therapist from France. In order for a person to be completely healthy, all of the visceral system must have proper motion. Emotion in our lives is also thought to make a great impact on our body's function. Jean-Pierre believes our organs are extremely receptive to our emotions and feelings. So one of the sensitive organ or which can react is our gastrointestinal system. It's called a second brain. It has its own way and it can react, and they're very sensitive to whatever happens around us, and they react very rapidly. The emotional reactions can range from simple spasms in the gallbladder to heartburn, vomiting, feeling faint, actually fainting, ulcers, and more serious diseases. Everybody will can recall when you wait for your Viva and you wait outside, you got the examiner inside and you are going to the next person going in. What do you feel? Yeah, everybody would have felt it. Okay, feeling some butterflies in the stomach or going to the restroom. So we feel some kind of, so all this reactions, your sympathetic reactions which happens, and our gastrointestinal system is very sensitive. They react for all these things. And once that kind of situation vanishes, we forget about there is a gastrointestinal system which has reacted so much. But every time we undergo some kind of stress related situations or environment, every time this gastrointestinal system goes into the kind of actions, reactions which we don't realize. And later on some point of time where you start getting some kind of indigestion, some kind of gastric symptoms, then only you start noticing what's happening. So recurring emotional stress can exhaust an organ and restrict its movement. It is speculated that up to 90% of musculoskeletal problems have a visceral component. Orthopedic manual skills, whatever we have gained already in physiotherapy, like your manual examination, your special test, your movement quality, movement assessment, quantity, all these things are relevant. And the specific exercise programs are also relevant, and they are all integral part of our treatment. As physical therapists, we have been trained to deal with multiple systems at once, and we have an extensive background in the structures of the spine and extremities, emphasizing the importance of articulation for movement. Okay, and before going into movement system, I would like to tell how the Barrel started this. So Barrel is basically a physiotherapist. After that, he has done osteopathy. He was seeing patients. It happened so that he treated a patient who had a back pain, fine, and then he treats, and then he meets the patient after 2 to 3 months. And when he sees the patient back, patient says, "I'm feeling all right. My back pain is gone. I'm feeling good." Then Barrel also, "Oh, that's really good." But the patient responded telling that it's not because of you. Okay, it's because I met people at Alps mountain who are tribal people. They did something in my abdomen or the stomach, and I felt better. Okay, he thought, okay, something they have done. Then he just left it. Again, within short duration, he got another 2-3 patients who came with the same story, that we had this problem. We went to the tribal people and they did something on my abdomen. Again, I got better. Okay, this intrigued him and thinking why it happened, how it happened. Then he went back to the literature, he went back to the anatomy. He looked at the visceral system and their attachments to the musculoskeletal system, and that's how he started developing this visceral manipulation. And that's how we have this technique which can be applied on the abdomen, and you can see the results. And most often as a physio, we don't have this in syllabus, but when the patient comes to us, that's not the case. Patient doesn't know that we don't have a syllabus. Okay, and the organs doesn't know it's not there in the syllabus. So when we see the patient, we don't understand why the patient is presenting with pain in the abdomen or in the groin or in the left or right iliac region. So most often patient comes and complains, "I have pain at the left iliac region above the hip," and let it be any medical specialty, let it be physiotherapist, anyone, they start thinking it's coming from the back. And whole movement examination, MRI, whatever is done, it's done for the back, and expecting the pain is referred or radiating from the back. That's what everybody is looking for. And as it is always said, patient is always speaks truth because that's his problem, right? As a physio, we don't understand from where it's coming. It's our problem, and most often we tell patient that's not no, it's not a problem in your structures. It's a problem in your brain, and we tell them you go and meet some psychologist. So that's the way we approach. That's the way we say, because we are not aware of that no kind of structures which can be a source of pain. So that's kind of no a limiting factor. As a we go with our no curriculum and we restrict ourselves and we say it's not within our syllabus. Yeah, but patient comes with a problem. So if we want to address it, it's up to us, and if we don't want, that's also fine. So coming to movement system, to have a good ideal movement, we need to have several structures or the system which should work optimally. So you got a articular, you got muscles, you got neural, fascia, visceral, central nervous system, and psychosocial factors. So to do an ideal movement, let it be shoulder, no, hip, lumbar, you need to have all the systems which works together in an optimal way to have a good movement. If you have any problem with any of these systems, then you got an impaired movement or you got an altered movement, which is our area of interest as a physio. What is the relationship between internal organs and motion system? So it's known as viscerosomatic. Viscero is, it's organs. Somatic is your muscle, joints. Okay, so that's your somatic. So there is a reciprocal relationship which exists between the visceral and the somatic structures. Dysfunction in one system is reflected as a disorder in the second system. So this is a picture where you got the spinal cord. Okay, you got these visceral organs. Okay, and then you can see the interneurons, which is connecting between your visceral organs and also the musculoskeletal or the joints and the muscles. So they are interrelated. Your problem in the joint and muscles, you can have a kind of pain location in the abdomen or the organs. If you have a problem in the organs, you can have a pain or a referred pain, which can happen in the musculoskeletal system. So they are both can influence each other. So we can diagnose the disease as somatic if it's purely starting from the muscle, bone, and joint or the nerve. We can call it as purely visceral disease if it's purely starting from your visceral organ. Or you can have a problem which starts with viscera, okay, and then gets reflected in the muscles, bones, and joints. It's called as viscerosomatic. This you will come to know through the history. Patient says, I got an ulcer. Patient tells, I underwent some surgeries, okay, and then after that I got the knee pain. After that I got the shoulder pain. Then most often that will be viscerosomatic. Or you can have patients who had purely had a back pain and then started having pain in the abdomen, anterior, lateral. Then it could be somatovisceral. So you can classify patients like this, and it's very easy to pick it up and treat the patient accordingly. So the stomach, if the person has got some issues on the stomach, you can have tenderness, spine tenderness from thoracic T4 to T7 spine. Okay, you can have a tenderness. If you have a problem with liver and gallbladder, you can have a tenderness at thoracic spine 6 to thoracic spine 9. If you have a problem with kidneys, again, thoracic 10 to L2. Gynecological organs, L2 to S1, pelvic floor, SA joint. So these are the areas where you can get a pain when there is a problem with gynecological organs. You can see it's quite extensive, and you get a patient who has got a history of hysterectomy, patient who has got some cyst, okay, patient has got some issues with the pelvic organs, repeated urinary tract infections. And then you get these patients and they come most often with your back pain, SA joint pain, right? Groin pain. It's not simple, straightforward. You do a muscle release, you do a taping, or you do a dry needling, you do some strengthening of, so it's not going to be that simple. So you need to look these organs which could be the source for those pains. So this is a picture of gastrointestinal system. You can see liver, stomach, okay. You got a colon, you can see it's all wrapped up. You got a visceral peritoneum, which covers closer to the organs, and then they are covered by parietal peritoneum. Okay, so and you can see this peritoneum layer gets extensively, or no, it gets attached to the lumbar spine. Can you see this? So it is like a bed which is lying down on the lumbar spine. So you have got some problem with the gastric issues, some kind of issues happening at the small intestine, large intestine. It can influence the structures of the lumbar spine. You can see it's all no interconnected. You can't say it is hanging in the sky or it's hanging without any attachment. So same thing is the fascia. It's the fascia. It wraps around the no organs, and it's like a gift wrap, and you can see all the organs are connected, and again it's all wrapped up and has got attachment to your musculoskeletal structures too. So what is visceral manipulation? Is a gentle, non-aggressive form of manual therapy that specifically targets the internal organs, how they articulate their support structures and their physiological functions as well as dysfunctions. So it's a very gentle therapy. The word manipulation is a little misleading because we are used to manipulation means grade 5. No, it's not. No, it's a very gentle and soft treatment, which is specific to the organs. And how we talk about biomechanics of shoulder, knee, and elbow. Same way here they talk about no movement of organs in the medial, lateral, superior, inferior, internal, external rotation, and there are ligaments which are attaching to the no organs to the above and below structures, which can get stiff when you mobilize it, and you will see the movement getting better and pain reducing and range of motion improving. So that's how it is. So what are the structures? All the structures starting from your no stomach, your duodenum, gallbladder, small intestine, large intestine. Okay, so all the pelvic organs all are included in this. Your lungs, your heart, where the ligaments are attached, superior, inferior, anterior, and posterior. When there is a proper indication and your assessment shows, you treat. It's a very specific treatment. You do a specific treatment, you will see the change immediately. So on MCQ, patient with right shoulder pain, which visceral structure can refer pain? Stomach, liver, heart, large intestine.
Just wait for a few seconds, sir, because there will be delay for 6 to 8 seconds.
Okay.
And I have also posted.
Okay. Just let me know when I can move on.
Yes, sir. And also I request the participants, there are more than 180 viewers currently following us from very start. So few are answering heart, and one is answering liver. Mostly they are saying heart. Among 6-7 answers, between heart and liver, they are answering. They are not answering stomach or large intestine. Mostly
Okay,
heart, sir.
Right. So it's a right shoulder pain. Heart is on the right or left?
One answered is stomach. Mostly now it comes liver, sir. After your saying which side you have to think. So the answer has been changed.
Okay.
Now mostly.
Good.
Yes, sir. Yes, sir. Left is heart. Heart is left.
Okay, good.
Yes, sir. Yes, sir. Yes, thank you. Thank you. We can go with the session, sir.
Yeah. So there's a small video where it shows the relationship of breathing and visceral movement. So if you see the visceral organs, okay, so they got two movements. One is known as mobility, other is motility. Mobility means visceral organs keep on moving. It's not like no, we are there and it just sit quietly. No, because our breathing and the diaphragm, okay, and the diaphragm which is connected to the liver on the right and the stomach on the left, you got the connections, you got the attachments to the diaphragm. So every breath you take, your visceral organ moves. This is known as mobility. Not only that, your blood flow, your heartbeats, all these things causes movement of these visceral structures. And for any reason, if your breathing is affected, can be because of the stress, anxiety, can be because of post-operative conditions, can be because of abdominal surgeries or thoracic or cardiac surgeries. it can influence these changes in the rib cage or the diaphragm, and that can in turn influence the movement of the organs, and that can affect their functions. So that's known as mobility. And there is a motility. What is motility? Motility is the organs have their own movements. That's how you got your digestion happening. That's how your gastric all the structures or the fluids which passes through the intestine system. So they have their own motility and they have their own mobility. So if these things are get affected, then your functions get affected. So you can see in this. So we breathe like 12 to 16 breaths per minute, and you can see the diaphragm moving up and down. And with that, you can see the whole organs, okay, your visceral organs moving up and down. So we take almost 24,000 breaths in 24 hours, 22,000 to 24,000 in a day. So that many times your organs are moving, and you got any problem, anything related to breathing, that's going to affect the visceral movement, your posture. Okay, as a physio, we are interested in posture, long time sitting, okay, sitting slouched, okay. Nowadays, you see all the IT professionals sitting for 8 hours, 10 hours, 12 hours. This is going to affect their intestinal movement. That's how people land up with constipation or digestion issues, then regurgitations. All these are very common, okay, and we see this day in and day out. So this is a cadaveric anatomy, just to give a idea of, okay, so that's your diaphragm at the top, and you can see this is a liver, and the liver has got the attachment to the diaphragm through right triangular, left triangular ligament and the coronary ligament. So that's your bile duct. Esophagus continues as the stomach. That's a pancreas. Duodenum, and you got the small intestine, which is around 6 meters in length. And then the whole organs, they sit on your posterior abdominal wall. That's your kidney. And they sit like a bed. And this is your muscles. This is your psoas major. That's your quadratus lumborum. So it's all connected. You can't say it's all lying with each other. You can't say it exists separately. Just to give an idea about that. Fine. So this is another video. So you can see the extensive kind of attachment of this, again, your small intestine. Okay. And you see it's a fresh cadaver. The peritoneum, parietal peritoneum, which is attached to your lumbar spine. You can see that when you move the small intestine, you can see the whole body, the whole cadaver moving. So that's a kind of strong kind of attachments which exist and which can influence your lumbar spine. And if you see in Ayurveda, for chronic low back pain, there is so much of evidence, okay? And they found that whenever they give gastric wash, it's one of the treatment in Ayurveda, and they found that chronic low back pain reducing significantly. For this, there is so much of evidence is there, again, which shows the strong relationship between your gastrointestinal system and your back pain, chronic back pain. So MCQ, what is the length of small intestine? Can we have answers?
Yes, sir. Let us wait for a few seconds, sir.
Yeah.
I request the participants to answer the MCQ. What is the length of small intestine? Now there is a new MCQ in the screen. The 6 meter, 6 meter, 16 meters, 9 meter, 6 meters,
okay.
25 meter, 9 meter, 6 meter.
Okay. So it is between 6 to 7 meters. Anything between that is okay. Fine. Shall we move on?
6 to 7 meters, sir.
Yeah.
So mostly 6 meters are answering, sir.
Yes.
Thank you all, sir. We will go back to the session, sir.
So I'll share with you the case histories, the patients whom I treated. So which will give you an idea, like, what kind of patient presentation and what kind of treatment was given and what was the outcome. This is a Mrs. X, female patient, okay, age 21 years, comes with a chief complaint of pain at right lower thoracic region and rib cage, okay, for last 3 weeks, right thoracic region and rib cage. So that's a pain. Posteriorly and also laterally, the patient was complaining of pain. The pain was gradual in onset. Location was right thoracic region and rib cage. It's a dull aching pain. It's intermittent in nature, and it is there for last 3 weeks. And it gets aggravated by forward bending and sitting. Gets relieved by supine position, and the severity was 8 out of 10, and the irritability was moderate. So this patient, it was most often it was related to the liver, the assessment, and the movement restriction was there when I assessed the movement of liver, and I found restriction when I moved the liver to the side bending and rotation to the right side. It was restricted, and it produced the same pain what the patient was complaining. So the release is done in the slouch sitting position, okay. And there's the liver and under the rib cage on the right side. So we use our hands to reach the liver in a slouch position, and we check the mobility of the liver moving side to side, up and down, and also rotation. And we find the side of restriction, and then accordingly we do a release of those ligaments. So most often the ligaments which are involved will be at the right side top. It's a triangular ligament which is getting attached to diaphragm. That's known as right triangular. On the left side, it's known as left triangular ligament, which is attached to diaphragm. At the top, it's known as coronary ligament. Corona means crown above the liver, so which is known as coronary ligament, which gets attached to the diaphragm. Okay, and also you got a falciform ligament which goes all the way, gets attached to umbilicus and goes all the way to urinary bladder. And then you got the ligaments which are below, that is ligament which attached to your stomach, your duodenum is to the lesser omentum, and then you got a ligament which attached to kidney and also the colon. So through the assessment, we find which is the direction of limitation, and accordingly we treat, and patient gets release, and then pain gets reduced. Okay, so that patient almost I treated for 3 sessions weekly once, and our pain became 0, and also the And this other patient, Mr. X, age 45 years, came with chief complaint of pain in right lower abdomen for past 1 week. Occupation, physician, that's a pain location, okay? Right iliac region. Onset gradual, location on right iliac region. Type, it's a sharp pain and intermittent in nature. It gets aggravated by sitting and sit to stand, okay, because being a physician, need to sit for longer duration, and after finishing the consultation, when the physician moves from sit to stand, again he feels the pain. So sitting is a provoking factor, again sit to stand is also provoking, and he walks for some distance, then the pain reduces. It gets relieved by walking. VAS is 6 out of 10, irritability mild, and he didn't have any of the systemic symptoms like nausea, vomiting, weight loss, no past surgical history, nothing significant, no significant personal history, medical history also not significant. And being a physician, he already underwent these investigations like CT abdomen and ultrasound abdomen, and all were normal, and he was looking for solution, so he landed with me. Okay, so I thought of possible differential diagnosis, appendicitis, renal stone. Again, all this he met already, he has taken all those investigations. From a physio point of view, could be a psoas major trigger point, could be a sacroiliac, could be a hip pathology, okay, could be a cecum restriction in the point of view of visceral, or it could be a hernia. So based on the differential diagnosis and the palpation, ruling out the psoas, ruling out sacroiliac and hip. Okay, based on palpation also, I diagnosed as cecum restriction. So I did the treatment, which involves cecum mobilization in supine position for 4 to 5 minutes. Okay, that's your cecum. Cecum is a place where your small intestine enters the large intestine, and that's a part, the initial part of large intestine. That's your cecum. So I did the mobilization. So it has got ligaments known as medial ligament, inferior ligament, and lateral ligament. So he had a tenderness or a no when I mobilized the medial ligament. So I did 3 to 4 gentle mobilization of the medial ligament. Okay, followed by that, he tried to sit up. Okay, he sat for some time. Was 0. Again, he tried sit to stand. It was pain-free. It was a single session. And again, I met him after 4 weeks. Again, he said the pain is 0 and all those movements are pain-free. That's the kind of end of the session, like or no outcome. This is the other patient, very interesting. Mrs. X, female, 40 years. Chief complaint of pain in left leg, more over hip region, laterally, anterior, and also laterally. Okay, pain over left limb, more towards the hip region, laterally since 5 years. So it's quite long. So that's our pain location on the left side, and pain was coming down to our anterior thigh and also the lateral thigh. It was gradual in onset, location on the left hip, also left iliac region. It's a dull aching pain, continuous in nature, duration lasts 5 years. It gets aggravated by long standing, sitting on lower height, chair, walking, cross leg sitting, stair climbing, sleeping on same on left side. So when she came, when she was like sitting on the chair also, she was not loading on her left side. She was sitting on the right hip. So it was that painful and she can't load on her left hip while sitting. So that's the kind of pain. And the way she was explaining her pain history, she was literally on tears because she was struggling for last 5 years. She has taken, she has met, she has taken all the investigations possible. Everybody said everything is normal from gynecological perspective, or musculoskeletal, orthopedic perspective. So from the urology, so all the things, everything was like like normal, and she was going around the hospitals. So it gets relieved by lying straight, and the severity of pain was 8 out of 10. Irritability is severe, and she has sleep is affected and not able to sleep on the left side due to pain. So that's your sigmoid colon, which is located on the left side. So based on the examination and palpation, when I palpated the sigmoid colon, she produced the same kind of pain which she used to get on her lateral thigh and the anterior thigh. So I did the sigmoid colon mobilization, and immediately post-treatment, maybe I took some 8 to 10 minutes, and she could sit comfortably. After 5 sessions of treatment, weekly once, our VAS came to 0, and that was about her. And also her functional activities significantly improved, like walking, sitting on low height, stair climbing, cross leg sitting, and sleeping on the left side also, she could able to do that. Okay, so this is a last case which we have started initially when I started the session. So Mr. X, 19 years, complaints of left chest pain. Okay, occupation student, pain or left chest for past 2 months, no trauma. Only significant history was he lost his father 4 months back. It was gradual in onset, and the VAS was 8 out of 10. And he already met cardiologist and orthopedician, getting clearances and finding were normal in all those investigations, and that's how he's landed. On observation, he looked dull and less communicative. Left side chest wall was stiff compared to right side chest when he did the palpation or the movement assessment of the chest. But thoracic range of motions were full. Side bending, rotation, flexion, extension, all the normal movement examination of the thorax was full. And what could be the possible source and how to treat, whether this patient is within the scope of physiotherapy? So we need to ask this question. Okay. And based on the visceral manipulation assessment and concept, so where the visceral manipulation, they assess and treat thorax. Okay. So in which some your techniques to assess the chest wall. Okay. And I did those assessment. Mainly you got a costo-mediastinal and diaphragmatic recess. So this is not this is apex of the lung. Okay. so you got a pleura here, okay, and you got some space here, okay, and also you got some spaces like mediastinal, costo-mediastinal recess, and you got a costo-diaphragmatic recess. Okay, these are the spaces where the lung can expand and you got a movement which can happen. But whenever a person is on stress, on sympathetic nervous system, person breathes shallow, okay, small breaths, then these rib cage gets stiff, and sympathetic system, your cortisol, your adrenaline, all these things leads to stiffness of your muscles. You can have trigger points in the muscles. Okay, so these are the effects which can cause restriction of these movements. So you got a technique where we release superior pleura to release a pleura superiorly. Also, we have technique for costo-mediastinal area where we can release it, costo-mediastinum. You got techniques to release it, and also you got costo-diaphragmatic. You got techniques to release. So I treated with these things, patient, and also we got pericardial ligament. So you got the heart, you got superior sternopericardial ligament, you got inferior sternopericardial ligament, which can be released. There are some gentle movements through which we release it. And then these are the techniques which I performed on these patients. Fine. Post-treatment, immediately, the VAS came down to 5. And by the time he left the room, I could see a smile, which was he was very stiff, very, didn't have a social smile. By the time he went out of the room, he was smiling and going. That was immediately after session. And after 3 sessions, his pain was 0. Along with this, I advised to meet a psychologist, and also I advised to go for a kind of, some kind of aerobic activity, kind with cycling, swimming, whatever he, is feasible for him, whatever he likes, some kind of physical activity. So that's what I advised him. Okay, so there is a study which is done on visceral manipulation on forward yet posterior and chronic non-specific neck pain, in which they used same kind of techniques what I have just explained on the pericardial ligament and also on the pleural ligament, and they found a significant change in the posture, and also on the forward posture, and also on the neck disability index, they found the changes. So what is the possible mechanism, how it works? Visceral manipulation is a soft tissue mobilization. The abdominal and thoracic organs are enveloped in the connective tissue of the facial membranes. As soon as we manually manipulate this visceral soft tissue, we are affecting changes locally and in surrounding areas because of their facial connections. And these fascia have huge number of mechanoreceptors, 100 million neurons, which is found in your visceral ligaments. And through manual manipulation, we change the viscosity of the ground substance, and also we lower the sympathetic tonus. So whole your gastrointestinal system is supplied by vagus now. You do anything on the abdomen, okay, your sympathetic system is going to get reduced and your parasympathetic will get increased, and the patient will feel much better, relaxed, calm. And that's the effect which can happen when you touch the abdomen and you treat. And Pacinian corpuscles are also found in the peritoneum and can be influenced by manual therapy. Also, there is another mechanism which is put forward by Donald E. Ingber at Harvard Medical School. He introduced the concept of cellular mechanotransduction, the process by which cells sense mechanical forces and transduce them into changes in intracellular biochemistry and gene expression. So it's known as mechanotransduction. So there are some more studies where there is a study which is active visceral manipulation associated with conventional physiotherapy in people with chronic low back pain and visceral dysfunction. It's a randomized, controlled, double-blind clinical trial, and they found significant change after 5 sessions once a week. Okay, they found there is significant change in your pain and disability, and also improvement in the lumbar mobility and the functions. There is other study where they have done immediate effect of sigmoid colon. So they have done manipulation of sigmoid colon, and then they checked that the pressure pain threshold of the lumbar spine, and they found that visceral manual therapy can produce immediate hypoalgesia in somatic structures segmentally related to the organ being mobilized. So this is done in asymptomatic, but still it gives some evidence that you work on sigmoid colon, your pain pressure threshold of the lumbar spine reduces. So if you have a source of sigmoid colon, you can imagine that the patient might present with back pain or can have a referred pain, and you treat sigmoid colon, the pain might reduce. This is the other study which is done on, on chronic neck pain. They have done visceral manipulation for liver and stomach, and they found that EMG activity of upper trapezius and range of motion getting better, and also neck disability index getting better. So this is a study which is done. It's a case report, 5 case report, which is done on cerebral palsy kids with chronic constipation, and they found after giving visceral mobilization, they found the colonic motility improved through radiographically before and after treatment. Okay, and the bowel movements getting better for 100% of the patients, participants. So you can imagine, about the immobility of cerebral palsy kids. Okay, and this has helped them. This can help. Patient with history of appendicectomy 2 years back, currently complains of back pain. He can be classified as visceral, somatic, viscerosomatic, somatovisceral. Can you answer this?
So let us wait for a few seconds.
Yeah.
Dear participants, the MCQ is on the screen. Patient with history of appendicectomy 2 years back, currently complains of back pain. He can be classified as visceral, somatic, viscerosomatic, or somatovisceral. Kindly put your answers on the comment. Who answered viscerosomatic? 1 visceral, mostly C. Viscerosomatic. Let's wait for a few more seconds, sir, because many are answering.
Yeah.
Hardly get only one answered D, somatovisceral. All are answering C. Was more than 40-50 members answered, sir.
Okay. Okay.
And mostly 95% it's C.
Okay, that's good. So you can see the patient had a past history of appendicectomy. Okay, after 2 years, patient complains of back pain. So you can know. So first initially start with viscera, now came to somatic. So it is a viscerosomatic. Same way, you got a patient with knee pain. I have seen many patients as a history of female patient as a history of hysterectomy, and then complaints of knee pain. Most often, it's again viscerosomatic. For these patients, you do any amount of therapy in the knee, it's not the source. Instead, you work on the visceral organs or the related organs of the pelvic. You will see the patient improving drastically. So to understand what is causing what is the reason, right? So that gives us a very clarity of direction. Instead of treating the knee, you treat the viscera and you get the solution. So that is a viscerosomatic. Suppose as a physio, we are very good at somatic. We know how to diagnose muscle. We know how to assess joint. We know how to assess the fascia. We know nerve. So we are very good at this, right? So we are very clear with somatic. There's no doubt about it. As a physio, we are the best people. We put our hands on palpation, movement examination, differential diagnosis, we do it. However, when we have this combination, whether it is viscerosomatic, right, or visceral, that's where that's our limitation. Okay, but if we can have that kind of information, I think we understand the patient better. When we understand the patient better, I think our treatment approach gets better. We can give lots of solution to the patient. That's the thing. So to summarize, so we have seen what is the role of viscera in movement system and the interrelationship between musculoskeletal system and the viscera, interneurons in the spinal cord, at the level of spinal cord. Not only that, mechanical connections between your peritoneum and the musculoskeletal system on the lumbar spine, and also you got a femoral nerve, which again present below your cecum, which could be, if there is a tension there, you can compress the femoral nerve and you can get the pain along the nerve course. So you got these cutaneous nerves, which is lying, as we saw in the cadaveric anatomy. This visceral organ just lying as a bed on your quadratus lumbar and psoas major, and through which psoas major your whole lumbar plexus exit. Okay, and you have got problem with gastric system, some kind of things going on. It can definitely have influence on those nerves, and which can give rise to pain on your sacrum, in your lumbar, your knee. It's absolutely possible. Similarly, you got the neck pain. pain or you got a whiplash. Okay, so for which you need a integrated or multidisciplinary approach for whiplash. Physiotherapy alone doesn't work. You need to have multidisciplinary approach. Again, which I found there are ligaments on the lung which has got attachment to the vertebra. So those ligaments are real. Okay, anatomy is real. So if we can address that, again we can give good improvement to the patient. So we have got these connections. Again, your frozen shoulder, relation to the liver, your posture, sitting slouch for long time. Most of the immobility related to your postural thing will have a component of viscera. And if we can assess that along with our routine musculoskeletal, I think we can make a difference to the patient outcome and we can treat the patient as a whole. So I'd like to thank organizers for the opportunity, Mr. Chandramohan, for putting all the effort and making this happen. Thanks for your time.
Thank you, sir. Thank you so much for a wonderful session. I have posted the Zoom ID and password in YouTube. I request participants, those who are having doubts, can interact with our resource person. Kindly join with our Zoom meeting. Sir, let us wait for a few seconds, sir.
Yeah, sure.
You can do screen share stop, sir.
Yeah.
I think. And those who are watching in the YouTube, if you have any doubts also, you can write in the comment section. I will read it here. You can keep watching in our YouTube also. Yes, Vinay Kumar, Rajesh Kumar as joining. Let us wait, sir. You are joining now. Now, madam, can you check whether there are any questions in YouTube? No, sir.
Yes, sir. I'm checking.
Yes, sir.
I'm
Meantime, we
actually
have got a question, sir, from Nirali Pandya. When pain is related to viscera, is then there will be full range of movement of joint or it will be decreased?
Yeah, that's what. As I said, it depends on the location of the which organ we are talking about. Fine. So suppose related to something like something like liver, something like large intestine. Yes, your lumbar range of motion can be limited.
Then the next question is from Ravi Verma. Does this manipulation has grades like Maitland?
No, it doesn't have grades. Okay, it's a kind of soft tissue mobilization. Okay, but it is very specific. So your hands, your direction of the movement, it depends on the ligaments, what is stiff, what is not moving, or the movement which is limited. It's specific, but it's a soft tissue release. It's not no, it doesn't have grades.
The next question is from Pushpa Jha. Sir, where to study from? Where to get to study this technique of visceral manipulation?
Yeah, as I said, this is developed by Jean Perry Barrel. So you can check Barrel Institute, okay, which is a kind of worldwide. They are the people who organize and they conduct these courses, and you can attend them. It's all available online.
And there is another question from Shubham. Please tell us about the techniques and applications for visceral manipulation. Sorry, Shubham, this is just to give an introduction. The techniques and applications should be trained manually. You need hands-on technique. And the next question is from Ashraf Yasin. Sir, what about IBS? Sir? Is it required to consider all parts of body to mobilize?
Irritable bowel syndrome. Yes, so irritable bowel syndrome. It's a very hyperreactive gastrointestinal system. Yes, we can help them and we have to see what kind of problem they have, right? They have lots of pain on the abdomen, right? Yeah, it helps. It helps.
Yes, sir. Thank you. The next question is from Shahin Qureshi. How to palpate the visceral organs?
Yeah, that's what. As Chandramohan sir said, it's an extensive hands-on kind of approach where you read very detailed surface anatomy, okay, and you got landmarks which can be palpated. And during the course, they do this very extensively, and right. So that's how you learn. So it's just an introduction. I have given a snapshot of what it is, and I have given the case histories, which gives an idea know what it is, what kind of subjects we can apply, and how is the outcome. So I have given an idea. So further to it, it needs extensive hands-on training. Okay. Yeah.
Thank you, sir. The next question is from Dr. M. Smriti. Sir, can we use same techniques in treating costochondritis?
See, costochondritis, already we have very established kind of mobilization, right? You got ribs assessment. We have got as a part of our musculoskeletal manual therapy, we got the glides which we can assess and we can treat. So that's very simple and straightforward when you tell costochondritis. Fine. The question comes whether it is visceral in origin. Suppose it's because of lungs, because of cardiac, as I discussed about that boy, who has got lots of, what you say, maybe because of emotions, loss of a person, which itself can trigger a kind of chain of events that leads to stiff rib cage. So if the source is visceral, then you need to think differently. If it's a simple, straightforward costochondritis, I think we have well-established treatment techniques which works well.
Thank you, sir. The next question is from Anita Sivan. Difference between viscera somatic and somatic viscera?
Yeah, as I discussed, somatic is nothing but your muscle, bone, joint, and nerve, which as a physio, we know very well how to assess them, how to provoke the symptoms, okay, and then how to treat. Viscera, as I said, again, based on the history, again, based on the palpation, you go and palpate those organs, and if they produce the same kind of pain, whatever patients I have shown you, when I go and palpate those patients, they produce the same symptoms what the patient was complaining of. So that's how we diagnose, and when we treat, and they get better. So yes. Viscerosomatic, as I said, a person gets a history of visceral disease, then gets a back pain, knee pain, viscerosomatic. Somatovisceral, patient gets a back pain initially. After 1 or 2 years, tells I have pain in the abdomen, pain in the groin. Okay, so that can be a reflection of a muscle problem in the organ. So that is known as somatovisceral. Visceral, it's a purely visceral organ. Somatic, it's a muscle, joint, and nerve.
Then the next question is from Nirali Pandya again. Like you said, gynecological problem in females, he is having knee pain. In that case, what to do?
Yeah, that's what. As I said, you got the nerves. As I said, lateral femoral cutaneous nerve, which comes, goes along the, below the cecum, and you got a, ligament of Clayt. You can check it, okay, which is connecting ovary, that ligament, and then when that gets stiff, right, and that nerve gets compressed, and the person get a knee pain, okay. So you can read on those cutaneous nerves and the nerves which goes underlying your large intestine, and that can have a referred pain going to the knee.
Yes, sir. The next question is from Savira Parveen. She wants to know regarding Pacinian corpuscle manipulation.
Yeah, see, it's nothing but the receptors. You got a stretch receptors, Pacinian corpuscles, Golgi tendon organs. So Pacinian corpuscle is nothing but the receptors which is present in the tissues. So which will respond to any soft tissue technique, massage, manipulation. So this Pacinian corpuscle present more. That means they will respond to this massage or the release, and that will can cause changes in those tissues. So it's all the receptors. Pacinian corpuscle is a receptor.
Yes, sir. The next question is from Ushi Jain. Visceral manipulation can help to treat migraine?
Migraine, that's what. Migraine, we have to see, is it because of the stress, because of, as I said, the stress component is quite high in migraine, right? So, and the stress has a significant impact on the gastrointestinal system. and you can see no, the central nervous system and the gastrointestinal system are very well connected. And you can go back and read the literature. Serotonin, which is a kind of no happy hormone, which is 90% is released by gastrointestinal system. So that's a huge amount. That's how you feel good. That's how you feel really good after having a heavy meal, and that's how you feel good. So that serotonin gets released. Not only that, you got the vagus nerve, which is no, which is your supplying to your gastrointestinal system, and it has a parasympathetic. You do anything on the stomach, patient might feel better. And migraine is again multifactorial. You can't tell it's because of only this. You can have muscle, you can have a cervical C0, C1, C1, C2, C2, C3, cervicogenic headache, which could be the possible reason for the migraine. So as a it's a multi disciplinary or multi structures in origin migraines. So there is no simple straightforward answer for this question, but you look for all these components and see what is relevant for the patient, and accordingly I think we can give a good result.
Yes, sir. Thank you, sir. And Rida Fatima is asking different, same question, sir, actually. And sir, example for that also we have answered. From Rashmi Shaini, is it similar to other physical therapies? Is visceral manipulation?
That's what.
Similar.
If you see, it is not part of physiotherapy syllabus. Okay, it's a part of osteopathy. Okay, and similar means I don't know what to answer. It's a kind of manual therapy approach, and as a physio, we treat extensively manually. So, and also we treat lots of back, knee, thoracic pain. So that's how I think anatomically it's existing. We can't say these structures doesn't exist. So, and also you can see it could be a pain source. So that's how we landed here.
And she is asking again, what are the main indications of visceral manipulation?
Yeah, that's what. As we say, neck pain, back pain, knee pain, it's all mechanical in nature. Same way, indication is it should be mechanical. Contraindication is very simple. You don't treat a infection. You don't treat acute patients. A patient coming with fever, patient has some systemic symptoms, we are not going to do anything. It's all pure red flags, contraindications. And mechanical, as we say, that means you will have this pain presentation which gets aggravated with some movements, and you have some movements which the patient feel better. And when you unload the structures, patient feels better. Then you know it's a mechanical nature. So that's an indication for the therapy.
Yes, sir. The next question is from Gautami. Sir, if pain in PSIS, lateral side from past 2 years, we can use same technique?
Yeah, that's what. It's very difficult if you ask this question, right? When you tell PSIS, it could be a pain from the SI joint. It could be a pain from lumbar spine. It could be a trigger point at the gluteus maximus. It could be a visceral organ, which is referring pain to PSIS. It could be a hip pathology. So there is no simple straight answer for this. You need to assess the patient. Without assessment, it's wrong to comment.
Yes, thank you. The next question is from Pauline Belcia. Is there any interconnection between piles and back pain?
Piles and back pain. Piles and back pain. So one thing is there. See, because of the piles, there is an anal sphincter which can go for spasm. Okay, anal sphincter which can go for spasm. So you got all this ischial muscles, pubococcygeus muscles, all these are there, which has the attachment to the sacrum and which can give a kind of pull and kind of chances are that patient might have SI joint or pain at the sacrum. That is possible. And if it's chronic in nature, the referred pain, it can go all the way to lumbar. That's possible. So if you get a history which started with the piles and then patient presenting with the back pain, it's possible the reason or the source is that piles, and secondary to that, something happening around that area and the muscle going for spasm, and chronic can present with back pain. So I don't know, I'm just telling, but it's possible. You can't tell it's not possible. Okay, but still you need to rule out your lumbar diagnosis, your movement examination. Okay, your all the you have to see whether it's lumbar in origin. So again, it needs an extensive assessment. There is no simple straightforward, yeah, this happened, this will be there. No, you do assessment, then you know what you are treating.
The next question again from Rasmi Saini. How can we know that pain will be referred to that area?
Yeah, that's what. If you see pain will be referred, so you got the structures, literature is very clear. What are the muscles when they are spasm or a trigger point? What is the referral pain pattern? It's all clearly kind of recorded. So you can go back and look for same way. You got a problem with appendix, you got problem with sigmoid colon. What are the referral pain patterns? It's all quite established. You can go back to the literature for each organ and you'll find this exists, and you can see whether when the patient comes with a pain in the particular area, what are the possible structures which can refer, and that will give you a lot of differential diagnosis. Further, you examine and confirm what could be the possible source of pain.
The same way, same question, different way. How could we know that the pain is in viscera or in muscle?
That's what, as I said, one is history. See, in our reasoning, clinical reasoning process in manual therapy and musculoskeletal, it's not based on one single assessment. It starts with history, your differential diagnosis, then you got an observation, palpation, you got a movement examination, musculoskeletal, active, passive. So it goes with the reasoning. For each thing, you will get a clue at each level, whether it's viscera or somatic. Okay. And then further palpation and then movement examination, you will understand whether it is visceral origin or somatic in origin.
Yes, sir. And maybe one of Manipal student, Dr. Vijayagiri, he completed. She is saying very good, great in-depth session, and looking forward for detailed session if possible to organize online. Sorry, madam, we are not organizing hands-on training sessions in online. And next question is from Ravi Verma. Facial manipulation versus visceral manipulation. Which one has more effect on easing pain?
See, that's what, it's all different concepts. So facial manipulation works on the fascia, okay, and they work on total. Like, no, they got some points where they release it, and if you see visceral manipulation, they work on the organs. Okay, they go specific organs. It has got biomechanics. Accordingly, they assess and they treat. So it's all different schools of thought. Okay, so it's not right to tell like no, this is better, that is better, like that. Okay, but everything it's a different school of thought. So you apply and see, and see the response.
The next question is from Anil. Sir, what are the red flags?
Yeah, as I said, infection, fever, any systemic disease. Okay, and yeah, so any systemic symptoms, vomiting, okay, a fever, rise in temperature. So all these things you find is definitely a red flag. And any acute trauma, again, red flag. Any swelling, edema, okay, all your signs of inflammation, it's a red flag.
Thank you. So the next question is from Mohammed Muzamil. Do visceral manipulation have better results in repetitive strain injuries? If yes, visceral manipulation itself is enough for to treat, or we have to combine with any other exercise or any other techniques?
As I said, see, whatever we do, our basic exercise therapy, our physical assessment becomes part of it. Without this, I think it's not possible to prevent recurrence, and to treat the patient as a whole. Our exercise remains integral part of our therapy, okay, which is quite evidence-based, and we have got quite a good amount of exercises, and which definitely I think helps the patient in the long run and to prevent recurrence.
The next question is from Kushi Jain. Why treatment session is once in a week?
Yeah, usually you do this soft tissue releases. Not only this, any soft tissue release or myofascial release you give, right? It takes at least a week to 10 days for we create a kind of micro injury. We create a kind of release, and the tissue heals, and we give time for the tissue to heal. That's how patient will have some kind of some soreness, some kind of reactions to the treatment, which takes at least 3 to 4 days to settle down. On the safe side, we give a week time so that the things settle down, and when the patient comes back, we know that okay, whether the pain is because of the treatment or post-treatment soreness or reaction to the treatment. So we give the time of 1 week. and then patient comes, we know what was the effect of the therapy.
Thank you, sir. And the next question is from Muhammad Musamil. How to explain the prognosis to the patient when they will ask about it? Because most of them are not ready to accept this.
Accept what? Means weekly once?
Maybe this technique.
Yeah, so technique, I don't know how to make the patient convincing, because if there is an indication, we request permission of the patient. Okay, is it okay? We are going to touch this part. Okay, if the patient says yes, then only we are going to not touch the patient. If not, no. Okay, and what I have seen is these patients are very chronic patients and they are looking for an answer, looking for a treatment. And if we can do something which can change at 20%, 30%, and they can improve their function, they can improve their ADL. I have seen patients telling that you do whatever you want, but I want the relief. I think that's the kind of patient or no, the need of the therapy. So that's how it is. If there is a need, I think patient will come to us. And if the patient doesn't feel comfortable putting the hands, I think we can also tell, yeah, we can't help it. Sorry. I think that should be fine. Yeah.
So maybe he is telling about the religious issue because he's asking about Muslim patient how to make them to convince for
exactly.
this.
Exactly.
Maybe that's why the question
what
came.
we can put forward. This is how the treatment is, fine. Or you arrange a female, okay, therapist who can treat them. It's not like that should be the answer for it. Yeah.
Yes, sir. The next question is from Neha Bajpai. Sir, if you are not organizing it online, then how and from where can we learn the technique? Neha Bajpai, it needs hands-on training.
Yeah, it
You
needs.
must
Yeah,
understand that.
Yeah, it needs palpation. It needs a kind of surface marking. You need to feel it. Where is the stomach? Where is the liver? There is a movement examination, right? When you feel it, whether you are feeling it right or not, that a trainer has to check. So it is extensively hands-on, treatment. So I don't think so. See, last 2 years pandemic is going on. You can go back and check in the Barrel website. And I think they didn't organize any online courses. Okay, courses are not happening all over the world because it's an hands-on, you need an interaction. Okay, and also somebody was asking where is the link for these research articles. You can go to the Barrel website, you go, there's a research section which is freely available. All these articles are full text, freely available. You can read more on it.
Yes, sir. The next question is from Anil. Sir, can visceral manipulation is used to treat diabetes?
Yeah, that's what. See, it'll have some effect, not to the extent you can expect that what you say, blood sugar levels will change, type 1, type 2 diabetes will change. So that much, no. So as I said, it's the mechanical restrictions, mechanical movements, and the pain related, which is shown to have a good improvement, and also gastrointestinal movements are shown to have a change following visceral manipulation, but not to the extent where you expect type 1, type 2 diabetes to or insulin to secrete more. So it's not there, that kind of what you say effect, or it's a mechanical treatment.
Yes, sir. So kindly explain the physiology about how the visceral manipulation is working on various visceras and working on so many systemic diseases.
Various?
So kindly explain the physiology about how the visceral manipulation is working on various visceras and working on so many systemic diseases.
See, that's what, so many systemic diseases, I doubt, right? We can't treat anything and everything. As I said, mainly as a manual therapy and pain management, we work on the pain. Okay, that definitely works. As I said, it's not like it's going to work for anything and everything. Fine, but it has an effect on the pain, and that's how I think we are restricted and specific to it. Not telling that we treat so many metabolic diseases. So that is not correct.
Sir, from Srivatsan Ramya Priyan, any materials that you can suggest and any classes and books you would suggest to study about visceral manipulation?
Yes, as I said, the Barrel himself has written books on visceral manipulation. I think that will be a good source, and you get all information in that. but it's all hands-on technique. By reading, I doubt how much you will get it. Okay, you can read definitely, but it definitely needs an hands-on palpation and training.
Yes, sir. We will read the questions from Zoom now. So far, I have read the questions from uh, YouTube. Let me go through here. Sir, from Rajesh Kumar, how to manipulate the liver?
Yeah, as I said, I showed you the hand position and the therapist and patient position, and there are some 7 to 8 techniques. Okay, depending on the patient presentation and the limitation. Okay,
Yes,
how is definitely needs hands-on training. Sure.
Yes, sir. Thank you. Nice answer, sir. And from Dheeraj, how is it useful in pediatric cases? Do you have any reference links for all the articles?
Yes, as I showed you on cerebral palsy, please go to Barrel website. You get full text research articles. All these articles are available, full text. More than this, it's available. So you'll have more information to read, and that will be the right way.
I request Rupesh to read the questions for a few minutes. And now I will take one question. Next question, Rupesh, kindly take care.
Yes, sir.
From Mervin Barnaba, can you brief us about connections between CNS and viscera?
Yeah, that's what, as I said, the gastrointestinal system is your second brain. Okay, and the neurotransmitters which gets released, your serotonin, you got other neurotransmitters which gets released in gastrointestinal system. They can go through blood-brain barrier and cause changes in the brain. That is one aspect. The other aspect is the vagus nerve, which is directly connected to your central nervous system to the gastrointestinal system. Again, you do anything on the gastrointestinal system can have an influence on the brain. So these are the two ways where CNS and gastrointestinal system are connected. That's how you feel, waiting for the exam, anxiety, any kind of stress. Okay, you go to restroom, all this because of these connections.
Yes, sir. Thank you, sir. Next question is from Mr. Sheikh Shaiza. So what can be the contraindications for visceral manipulation?
Yeah, this I think I answered. No?
Yes, sir. Next is from Mrs. Suganya Palanisamy. What's the relationship between hysterectomy and knee pain, sir?
Yeah, that's what, as I said, you got the cutaneous nerves and the nerves which is present behind your pelvic organs, where there can be compression or a stretch on these nerves and which can cause referral pain to the knee. That's a possible mechanism.
Yes, sir. Next is from Dr. Vinay Kumar. Sir, how to differentiate from inflamed organ and viscerosomatic pain?
That's what. Once you tell inflammation, you look for the signs of inflammation. Your redness, your fever, right? No, these things will tell it's because of the inflammation and it's a red flag.
Yes, sir.
And acute pain, again, we don't touch the patient.
Fine. The next one is also from Ms. Suganya Palanisamy. How do you differentiate visceral pain and visceral ligament pain?
Yeah, that's what. Visceral pain, what do you mean by visceral pain is nothing but which is starting or which has got attachments to the ligaments. That's where we are looking. So it's the organs and the attachment of the organs to the structures which is present above, below, and the laterally. Okay, so we talk when we tell visceral, it's most often the ligaments or the peritoneal layers which connects to organs around whatever organ, superior, inferior, lateral.
Fine. The next one is from Mr. Dheeraj.
Yeah.
Sir, reference link for all the articles shown can be given.
Yeah. I have answered. No, you can go to Barrel website. It's all there.
Fine, sir. In cerebral palsy patients, how is it useful, sir? Visceral manipulation.
Yeah, that's what. You can go back to that article where because of immobility, they have a problem of constipation. Okay, and this visceral manipulation has shown in that study radiologically that mobility of the intestine increases, bowel movements increases.
Yes, sir. Next one, can visceral manipulation useful for differentiate visceral organ pathology?
I'm not understanding what is visceral organ pathology. Yeah, it helps us to understand what could be the possible source of pain in based on the location, based on the symptoms, we can find which organ is involved and accordingly treatment can be applied.
Fine, sir. Next one is from Dr. Vinay Kumar. Sir, will the visceral manipulation cause pain to the patient?
No, it's a very gentle treatment. Okay, it should not cause. It can have some discomfort, no doubt, because we are going to not touch the painful spot. Some pain might be there, right? So that's what you need to understand patient's irritability, the severity, and accordingly you need to be gentle, and then it should be fine. So as I said again, no, it's not we read from book and do something. Be careful, don't do that, because it has lots of palpatory techniques and the patient response, it needs practice. Don't put your hands directly and it can really cause some damage to the patient. So it has happened also. I have seen people doing no vigorously or no without understanding how much force to apply, right? That can cause damage to the patient. So just a word of caution.
Yes, sir. Next one is from Ms. Amulya Datta. Sir, most of the patient are not aware about this treatment, that is visceral manipulation. They come to clinic for physiotherapy treatment only. To spread awareness about visceral manipulation, what we can do, sir?
Yeah, I don't know what to tell for this. For this, first, I think, no, as a therapist, we should be aware, right? And then the word of mouth, that's how I think it can spread. And patient find a relief, I think, right? Word of mouth is the best way, fine. And yeah, that's the only way. Or policies, something like that. Okay.
Yes, sir. Next one is from YouTube viewer, Mr. Pushottam Pradhan. Does visceral manipulation hurt? I think you have answered the same, sir.
Yeah.
Yes, the next one is from Dheeraj. Can visceral manipulation be a substitute for medical treatment?
See, that's what, as I said, this is a mechanical treatment, okay? And what kind of conditions we are talking about, we need to be careful. Medical treatment means you are talking about kind of gastric medications. You are talking about protein pump inhibitors. No, that's not the purpose of this treatment. It's a mechanical treatment. It cannot be a replacement for a medical therapy. That's not right.
Yes, sir. Next one is from again Dr. Vinay Kumar. Sir, are there any special tests or just palpation to diagnose the visceral condition?
It's extensively based on palpation.
Yes, sir. Next one is again from our YouTube viewer, Mohammed Muzamil. Can we encourage the natural healing mechanism in Parkinson's disease?
I don't know why this came. Natural mechanism in Parkinson. I don't know what is the question. Huh?
You might have thought that visceral manipulation may be done for brain or inside the brain.
No. So you got a different pathology in Parkinson's. I don't think so. But maybe the Parkinson patient have constipation. Okay, that's one of the early signs of Parkinson's. Okay, before the Parkinson's disease gets diagnosed, they start with constipation. So that can be helpful with visceral manipulation, but not to the pathology of Parkinson, which is definitely in the brain.
Yes, sir. Again, if you are asking about the contraindications of visceral manipulation, sir,
Yeah, I have answered that.
you can just go back in the YouTube and you can view it again. Yes, sir. Any more questions, ma'am? That's all from the chat box.
Let me check in
No
YouTube
more
once
questions have come
before,
in.
once
The
before
things
we
I
wind up.
pasted here. Rupesh, there is one question in your chat box, I think. Zoom.
Yes. In Zoom also, in YouTube also. In YouTube, I will read here from Krishna Kali Das. Yes, she is asking about sports where is happening. We have answered it already. You can get back to the video and you can know where it is available, and internationally accredited certificate where you get everything is explained already. And yes, no more questions will be taken from YouTube. Thank you, and get back to Zoom. What was the question, Rupesh? Can you
Yes,
read?
sir. I'll read it, sir. Last question from Mrs. Gautami. Sir, can we use same technique for AS?
Ankylosing spondylitis.
Again, ankylosing spondylitis, as I said, what is the indication? Suppose a person has got constipation, suppose patient has some regurgitation. So what kind of problems accordingly can be treated.
So one
Yes.
beautiful question came, sir. Actually, we cannot avoid it.
Yes, sir.
Sir, any manipulation for menstrual pain? Thank you, Neha, for asking this question.
Yeah, as I said, there is a level 5. I think they kept only for pelvic organs. Okay, where they treat uterus, urinary bladder. Okay, they treat ovaries. So there are some mechanical treatments which they do it. So it can be helpful.
Sir, does it helpful in infertility?
Yeah, that also some studies are there. Some kind of some treatments are there. We had some of the patients getting benefited because of mechanical restrictions. Okay, the reason is because of mechanical restrictions, infertility, and along with the normal medical management, when they take this visceral manipulation, so I think it helps.
Yes, sir. Then from Psych Sasha, sir, can we treat uterine prolapse with visceral manipulation?
Yeah, techniques are there. Yes, rectal prolapse, uterus prolapse, techniques are there. Yeah, it's there. Yes.
Yes, sir. No more questions, sir. So, thank you, sir.
Thanks for our participants for asking wonderful questions. Hope I have thrown some light, and then it makes it a little more interesting, and shows a different kind of aspect which is existing when we assess a patient. So that gives an opening for us to know more, to learn more, and understand the patient better. I think that will be good.
Thank you, sir. Thank you so much for accepting our invitation, and you have given us a wonderful session, sir. I have seen your videos already, and it was entirely different in the sense. And there are so many questions answered here that will also be useful for all the viewers who have attended or in future who are going through this video. This may be helpful for them. And I thank Professor Duna and Dr. Rupesh for their help to organize this session. And I thank all the participants who have registered. So we are going to post the registration certificate download link now in our YouTube comment section. And also we will be posting that in YouTube community section also. You can download your certificate. If you can't download, you can WhatsApp to our numbers. We will be sending you the download link and help you how to download it. Okay, thank you all.
They can directly go to our website and find it.
Yes, otherwise you can go to our website ExRxIndia.org and you can see the message over there, and there are steps given how to download. Properly go through it. In case if you cannot download it from your mobile, just try with your friend's mobile or laptop. Few mobiles cannot accept. There are very few. Rarely it happens, 1 or 2%. So you can ask a friend's mobile to download it, and or any laptop, desktop. From that you can download it. Once again, I take this opportunity to thank Dr. Prem Venkatesan sir for this wonderful session. Hope sir, we are expecting any other good topic also in the future. And thank you, sir. Once again, thank you all.
Thank you, Dr. Chandramohan, and
Thank you,
all
sir.
the organizers. Thank you.
Good night.